Then make a mic. Take a ton. Kerala the same. Then what making slide mark for an
Oh,
heroic.
Good afternoon. I warmly welcome you all for the clinical meeting of the month of March. Before that, I have to tell a few things. Now, we were able to open our account of the Clinical Society. I would like to thank Dr. Diyalagoda for special attention on that. These days, very difficult to open account for even for a society. So, that will help a lot. And the second thing is like we've been invited to do a joint session with the North Colombo Clinical Society. But Ishan sir had suggested like we will do our own congress and endorse them as partners, like endorse SLCP, North Colombo Clinical Society, and we will do the congress, first ever congress of the Clinical Society of Welisara. So we need your support, and probably it is on early May, 1st of May, tentatively, but Ishan sir will come and brief you today, right? And the third thing is like, what is it? We will tell also need to register for CPD. Now we have our account, and CPD is very important now. Like this year, like SLMC registration, like they did without CPD, but after 5 years, definitely they will ask for CPD to update your CPD points. So it is very important to have CPD. In the next 5 years, definitely they will ask for it. The process is going on. This time also, if you have registered, like they have asked for a CPD part also, like we can skip for this one, but next year, like, CPD will be very important part to get the registration of the SLMC. So these are clinical meetings and lectures that we can earn CPD points. So we will register on CPD also. And there will be I will share the poster, like there will be a SLM, Sri Lanka Medical Association walk tomorrow regarding water safety. If you have free time, like everybody invite you to join the SLM walk and go on phase 7A. You have time. Thank you so much. Then most important that now I'm going to introduce our one microbiologist, Dr. Kalani Diyalagoda, for today's lecture on basics of antibiotics, which is a very important topic, which I also personally interested in this topic because like antibiotics are very much misused by the prescribers at all levels, medical officers, consultants, even higher specialties. So the antibiotics being misused. So it's a timely lecture, and I would like to thank Dr. Kalani for agreeing to do the lecture today. So I will invite her to begin the lecture.
Good afternoon. I hope you all can hear me. I'm going to talk to you about antibiotics. This is a basic lecture, just the basics of antibiotics. What I'm going to talk to you is like what I'm going to introduce you what are antibiotics and a brief history, spectrum, and the classes and classification, a little bit about resistance, not much, and the antibiotic stewardship program. So what are antibiotics? So this word antibiotic came from this word antibiosis, which is the meaning is against life. So this was initially introduced in 1889. And at that point, he used this term to refer to the process of one creature destroying the life of another to sustain its own. But the problem antibiotic came in 1942. The proper meaning is a chemical substance of microbial, usually a microbial origin, that inhibit the growth or the metabolic activities of bacteria and other microorganisms. you must have heard these two terms, antimicrobials and antibiotics. Even though we are like synonymously use these two are, there is a difference. This antimicrobials, it has a broader meaning. It includes all the antivirals, antiparasitics, and antifungals as well. But when we refer antibiotic, it's just the chemical agents against bacteria. And the history. It is like the invention of antibiotic, like most of the scientific discoveries. This is also the antibiotic, discovery of antibiotic also is a kind of an accidental discovery. So this Alexander Fleming, he used to work in the bench with the organism. So one day he kept his plates, culture plates. He forgot to discard the plates. So he kept the plates. And 2 days later, when he come back and see these plates, what he noticed was there was a growth of mold on the plates, this Penicillium notatum. And I mean, where there is this mold, there is an inhibition of bacteria. The Staph aureus was inhibited at the points where this Penicillium notatum was grown. So he recognized that there is some kind of a chemical substance in this mold which inhibit this bacteria. But the actual extraction of penicillin took another decade. So the classification of antibiotic, these are like you can classify antibiotic according to these various terms. So first one is narrow spectrum versus broad spectrum, and the bacteriostatic versus bactericidal. And when you are treating the patient, empirical versus targeted treatment, and according to the chemical structure of the antibiotic, and according to the mechanism of action and the route of administration, whether it's prophylactic or the treatment. So when we talk about narrow spectrum versus broad spectrum, the broad spectrum antibiotic is an antibiotic that acts on the two major bacterial groups. You must have heard this gram-positive and gram-negative. Those are the two major broad groups of microorganisms, bacteria, or any antibiotic that act against a wide range of disease-causing bacteria. That is a broad spectrum antibiotic. And the narrow spectrum is antibiotic that is only able to kill or inhibit limited species of bacteria. So if you see this chart, so you can see that penicillin is active only against streptococci. And when you give amoxicillin, it has some gram-negative cover as well. And this flucloxacillin, it has streptococcus and this methicillin-sensitive staphylococcus. What I wanted to highlight here is this vancomycin, teicoplanin, linezolid, daptomycin, and clindamycin, even rifampicin and fusidic acid. These antibiotics only have the gram-positive cover. There's no gram-negative cover in those antibiotics, except very few. And clindamycin has some anaerobic cover. So if you go down this meropenem, that is the broadest spectrum we have. I mean, it has all the cover, gram-positive, negative, anaerobes. Other than MRSA, it would cover all the antibiotics, all the bacteria. So the examples of broad spectrum antibiotic. We usually, I mean, when a patient comes, we just prescribe antibiotics. So you should know the broad spectrum antibiotic, aminoglycoside. Ampicillin is a broader spectrum because it covers gram-negative and positive. Ampicillin and amoxicillin are having kind of a same spectrum. And the amoxicillin, clavulanic acid, and carbapenems, piperacillin, tazobactam, quinolone, I mean, ciprofloxacin, levofloxacin, and all included in quinolone, tetracyclines, chloramphenicol, ticagrelin, clavulanic acid, and this trimethoprim sulfamethoxazole. So now the second classification is bacteriostatic versus bactericidal antibiotics. So the bactericidal antibiotics will kill the bacteria. And the bacteriostatic antibiotic just prevent the growth of bacteria. These are the examples. These are bacteriostatic antibiotics. So this tetracyclines, clindamycin, macrolides, and the sulfonamides are bacteriostatic. And the bactericidal antibiotics are these beta-lactam group of antibiotic, which we commonly use, and the aminoglycoside, quinolones, and the vancomycin and glycopeptides, and metronidazole. So the next term I'm going to introduce is this empirical versus targeted. So empirical antibiotic therapy is largely based on experience, and therapy begun on the basis of a clinical educated guess. I mean, when a patient comes to admitted initially, we don't know what it is. We don't know what is the organism causing. At that point, we have to do a educated guess to start the antibiotic. So that is the empirical antibiotic, and which we have usually starting empirical antibiotic before the confirmation of a definitive medical diagnosis or without complete understanding of the etiology. So it should be directed against an anticipated and likely cause of infectious disease. And typically, usually, commonly, it's a broad spectrum antibiotic. And sometimes we have to start in combinations as well. So ideally, empirical treatment should start according to the local antibiogram. In our setting, we are majorly lack this because we don't have our own local antibiograms. And targeted treatment is once we identify the causative organism and the sensitivity pattern, we can start the definitive treatment. So according to chemical structure, the large group is this beta-lactam. Beta-lactam include penicillin, from penicillin to carbapenems. And the macrolides group is this erythromycin, clarithromycin, and all. Quinolone, that is ciprofloxacin, levofloxacin, those. Lincosamides. Aminoglycoside is this gentamicin and amikacin. Tetracyclines. These are the classification according to the chemical structure. And I give some examples of these antibiotics. Actually, penicillin, in the penicillins, all these are penicillins. So when you talk about this fourth one, piperacillin and ticagrelin, which that penicillin group has an anti-pseudomonal cover. And this timoxicillin, that is also a penicillin. It is usually used for the carbapenemase. We don't have it here. And we can use it for carbapenemase producing, against carbapenemase producing organisms only for UTIs, usually, complicated UTIs. And these are beta-lactam, beta-lactamase inhibitors. You know this augmentin in that. And we use ticagrelin as well as piperacillin and cefeprazone sulbactam as well. The last three things are, kind of new, and these are for these carbapenemase producing organisms. So we have ceftazidime avibactam in Sri Lanka. Other two we don't have. And the cephalosporins. So we have 5 generations of cephalosporins. First generation is cefalexin. You know cefalexin. Usually it has gram-positive cover and some gram-negative cover. And when it comes to second generation, the cefuroxime is what we know most of the time. And it has this gram-negative cover is more broader than first generation. When we comes to third generation, it has more negative cover. And this third generation cephalosporins, in addition to this more broader negative cover, it has a ability to penetrate blood-brain barrier. That's why we use ceftriaxone and cefotaxime for this meningitis. And when it comes to fourth generation, cefepime is the commonest one. And the fifth generation is cephalosporins with MRSA cover. And the carbapenems, these are the usual 4 carbapenems. Ertapenem is its ertapenem lacks pseudomonas cover. Other three has all the cover. And the macrolides, and this fourth one, pidoxomycin, is it's a macrolide which use to treat this Clostridium difficile diarrhea. We don't have it here, and it acts on the bacteria inside the intestine only. And the quinolones, there are 3 or 4 generations, I think. There are some other generations coming. So this first generation it has only gram-negative cover and usually used to treat for UTIs. And the second generation, it has added gram-positive and some atypical cover. When it comes to the third generation, moxifloxacin has anaerobic cover in addition to gram-positive and atypical cover. Gram-positive, negative, and atypical cover. And the tetracycline, it is also, there are about 3 generations. So this first generation is basic oxytetracycline. And when it comes to the second generation, it is doxycycline and minocycline usually. And the third generation is tigecycline, which we have in Sri Lanka, and it usually used for the resistant organisms. And this minocycline also, nowadays, we use to treat this multi-drug resistant Acinetobacter in combination. We use minocycline in combinations of other antibiotics. And these are the new antibiotics. So this cefiderocol, it is kind of a, you might know that there are these 4 groups of carbapenemases. I mean, when we talk about the resistant, I'm not going to talk much because that is a separate topic. So this cefiderocol has a broader cover. It will act on almost all the classes of beta-lactamases. So we can use it to treat resistant gram-negative organisms. And this ceftazidime avibactam, recently we have this NMRA registration in Sri Lanka. So that is also act on these resistant gram-negative organisms. And these others, other antibiotics, imipenem, relebactam, meropenem, babobactam, or these eravacycline and plasmomycin, we don't have. I mean, these are like this ceftazidime avibactam, imipenem, relebactam, meropenem, babobactam, and ceftolus and tazobactam. These are like beta-lactam, beta-lactamase inhibitors. Eravacycline is one of the newest tetracycline, and the plasmomycin is a aminoglycoside. So the mechanism of action. Before going into mechanism of action, it is better to know a little bit about this bacterial structure. So the bacteria has some bacteria has capsules, and usually almost all the bacteria have this cell wall, plasma membrane, and ribosomes to produce proteins and the nucleic acids. So these antibiotics we have act on these parts. So this is the difference between gram-negative and gram-positive bacteria. You can see that gram-positive bacteria has uncomplicated structure compared to this gram-negative cell wall. So it is kind of a complicated one. So that's why gram-positive organisms are easy to treat than gram-negative organisms. Resistant mechanisms are low in number compared to gram-negative organisms. So first one is the cell wall synthesis inhibitors. Commonly used antibiotic, beta-lactam group in this mechanism, and the vancomycin and other glycopeptides. And then protein synthesis inhibitors. I mean, these groups of antibiotic act on various parts of this ribosome. And the nucleic acid synthesis inhibitors. This quinolone comes here. And this is in one picture. I mean, you can see that inhibition of cell wall synthesis, that is penicillin, cephalosporin, and vancomycin. And protein synthesis, it's this macrolides, tetracyclines, aminoglycosides. And the DNA, it's quinolone, rifampicin, those things come here. And this sulfonamides also, it's indirectly inhibit the nucleic acid synthesis. And according to the route of administration, it's IV, oral, and the local applications. When we talk about the local applications, that could be eye drops, even application creams, and we use inhalational and intrathecal antibiotics. Those are local. And the other one is prophylactic versus treatment. So the prophylactic is like we use surgical and medical prophylaxis. So for surgical prophylaxis, usually what we recommend is to give the first dose of antibiotic 30 minutes prior to the incision, where we expect to prevent infections introduced from the skin or any colonized surface to the surgical field. That's what we expect to prevent by giving this antibiotic. Usually it's a single dose, and in some prolonged surgeries, you can use another dose intraoperatively. And some surgeries, you can continue this surgical prophylaxis up to about 24 hours. But you don't have to continue antibiotic until the drain removed. So the medical prophylaxis is usually given in rheumatic fever and some heart conditions to prevent infective endocarditis. And after splenectomy, we usually recommend penicillin prophylaxis. So those are the medical prophylaxis. And treatment for infection, other thing is treatment for any infection. So now I have given some classification. Now we'll move on to some other aspects when you use antibiotic therapy. When to use antibiotics in combination. So when we start empirical treatment for life-threatening infections, it would be better to use antibiotic in combinations. And sometimes when we suspect polymicrobial infections, such as if a patient has a perforated bowel or gangrenous bowel, in that case, we expect to have polymicrobial infection. And to prevent emergence of antibacterial resistance, that is used when you treat for this TB, tuberculosis. That's why we use antibiotic in combination. And for antibiotic synergy, this is usually used in infective endocarditis, where we use beta-lactam antibiotic in combination with an aminoglycoside to give the synergistic effect. And the other one is when we are treating for a multi-drug resistant organism. So when we are treating for multi-drug resistant Acinetobacter, sometimes we have to use antibiotic in combinations. And the other aspect is allergies to antibiotics. So when you take the history, and if a patient says that he has some kind of a drug allergy, you better ask these things. What is the exact antibiotic, whether it's for oral or IV form, and when really it has happened, whether it's last year or 20 years back, and what really has happened, whether it's just a rash and itching, whether it's a localized rash only or the generalized rash, or whether he had breathing difficulties and any heart abnormalities. And the other aspect is how was it managed, whether this needed ICU admission, hospitalization. Those things would be better to ask and record. If you have any doubt about these drug allergies, better to get the opinion from the immunologist. And the other aspect is treatment duration. So the antibiotic treatment, there are no hard and fast rules for antibiotic duration, except for these, even for collections, what we recommend is you need to give antibiotic until clinical, biochemical, and radiological resolution. So we can't give exact duration for anything. Usually this duration depends on specific infection, severity, and the patient factors. For most of the infections, including community-acquired pneumonia, even bacteremia, shorter durations would be, the shorter durations are not inferior to longer durations. So 5 to 7 days of antibiotic would be enough for most of the community-acquired pneumonia or even for bacteremia. And when we apply this knowledge, so we have to think about these these. I mean, when you come across patients, you have to think about above factors a little bit. I mean, it's like unknowingly you will think about these things. So mild infection not needing hospitalization, definitely you will select oral antibiotic, which is in a not that broad spectrum. So when a patient diagnosed with lung abscess. So here, it is very important that antibiotic will not reach this abscess or collection in adequate concentrations to inhibit bacteria completely. So it is very important to source control is very important when there is a collection or abscess or anything like that. However much we give antibiotic, this antibiotic will not reach that collection adequately. It will reach in some amounts, which leads to resistance. The other one is the septic patient admitted to ETU. When a septic patient comes, we have to, I mean, we can't wait. So we have to start a broader spectrum antibiotic. Better to start a bactericidal antibiotic here because we have to get the action quickly. And we have to consider the comorbidities, previous hospitalizations, and previous antibiotic treatments, cultures, allergies. All these things should be taken into account. So when we give antibiotic, there are some unfavorable effects as well. So the first one is disruption of normal microbiome. You know that on our body surfaces and in our gut and all, there are so many microorganisms. So when we give antibiotic, that these antibiotic will kill the pathogen as well as this normal flora. So that will cause several issues. So they have noted that these persons who have taken several antibiotic courses, frequent antibiotic courses are more prone to allergies because this normal microbiome is disrupted. And the side effects and allergic reactions, drug interactions, because some of these patients may have another drugs as well other than antibiotics. So there will be drug interactions and the antibiotic resistant development. So the next topic is like antibiotic stewardship. What is antibiotic stewardship? It's a systematic approach aimed at optimizing the use of antibiotics to improve the patient outcomes and combat antibiotic resistance. So why do we need antibiotic stewardship program? As you can see, until 1980, they have they have discovered or developed so many antibiotics. I mean, after 1990, there are no original classes of antibiotics discovered. So we don't have much antibiotics left with us. So the antibiotic pipeline is dry. This is a common slide. So as you can see, I mean, if you see that this penicillin was discovered in 1928, but the date of resistance identified is 1940. So this tetracycline, almost the same 1950s discovered as well as resistance identified. So, I mean, these bacteria are clever than us. So they developed resistant mechanisms when they were faced to these chemical agents. I mean, however much we expose bacteria to antibiotics, bacteria will develop resistant mechanisms. So these are the resistant mechanisms in one picture. I mean, either bacteria can decrease the uptake, or from the efflux pumps, they can put the antibiotic out of the bacteria, or they can have inactivating enzymes, or they can do the target alteration. So early in 2000, our culture plate, I mean, antibiotic sensitivity plate was looked like this. But now in 2024, it's like this. So many antibiotics are resistant. So we have very few by 2050, there won't be any left. So that is the reason we are introducing these antibiotic prescription charts and antibiotic stewardship programs and everything. So I just wanted to tell you about this form as well, even though nowadays we don't have it. But this is the form that is introduced by the ministry. So doctors need to fill some of these things, because usually nurses fill this patient name, age, and the ward and everything. You have to fill this allergy part as well as indication for antimicrobials. If you can see this form, so this form has these areas. So you have to at least tick this. I haven't seen any of these ticked. And you should mention whether you have taken the cultures. And the other thing is this you have to circle this. I mean, for the antimicrobial, it says PES, that is prophylactic, empirical, or the specific treatment. So the doctor has to do circle this thing. And below this antibiotic name, it says AW, access, watch, and reserve group. So AWR. So you have to circle this as well. And there are other things. I mean, after 2 days, you have to put your initial on these review points. And after even 7 days, you have to put another initial. So this form need to be filled. I haven't seen any of our forms have been filled. Nobody filled this. You have to fill it. So these are the severe classification of antimicrobials. So we have access group antibiotic, which you can prescribe kind of freely. I'm not saying it's freely, but any of you can prescribe this. So you must know these antibiotics. So I mean, access group include this basic antibiotic, amoxicillin, coamoxiclav, and ampicillin, clindamycin, these macrolides, doxycycline, metronidazole. Those things are in this access group. And this watch group antibiotics, this meropenem, and the third generation cephalosporins, this ceftriaxone, cefotaxime, ceftazidime, those are in this watch group. Because you can prescribe it, but you have to review it. And this reserve group antibiotics are usually given after authorization by the microbiologist. So this antibiotic classification differs from country to country. This is Sri Lankan antibiotics, how we classify, because usually levofloxacin in other countries, levofloxacin comes in watch group. But in our country, it's in the reserve group. And the principles of antibiotic therapy. This is from our microbiology book called Mandel, which is a big book. So the first principle is like proper selection of empirical antibiotics. Starts with an accurate differential diagnosis that includes slightly bacterial infection. So the second principle they give us is like, even in a patient with an obvious bacterial infection, treat only when therapy will alter the patient's clinical course. And the third one is empirically target the microbes that cause the diseases identified in the differential diagnosis. Fourth one, the critically ill patients, there should be a lower threshold for the use of empirical therapy. And the next one is host factors affect the breadth of empirical therapy by altering the probabilities of likely agents of infection. And the sixth is pharmacokinetic and dynamic principles can influence optimal therapy. Clinicians should de-escalate antibiotic therapy based on microbiology results and the clinical and biochemical responses. If therapy is not working, consider source control and alternative diagnosis before blaming resistance or the broadening therapy. And the ninth principle they give us is distinguish new infection from the failure of initial therapy. And the 10th one, the duration of therapy should be evidence-based with a bias towards the short course whenever possible. So with this acronym, even this could be enough. First one is Mind Me. Microbiology guide the therapy wherever possible. Indication should be evidence-based. Narrow spectrum therapy is preferred. And the dosage is individualized to the patient and appropriate to the site and type of infection. Minimize the duration. Ensure oral therapy is used when clinically appropriate. So these are my references. And this is the empirical and prophylactic use of antimicrobials. This is a national guideline, 2024. You can freely download this from the SLCM, Sri Lanka College of Microbiologists website. It gives empirical therapy for almost all the infections. Even prophylaxis, surgical prophylaxis, everything are given in this book. It's very difficult to give whole antibiotic in 1 hour. This is just the principles and the things for you all to think about. Just basics to think about.
What is the place for this nebulized antibiotic?
Usually, nebulizations are recommended in this ventilator-associated or the, oxygen required patients, not for just normal patients. And our setting, we don't have the proper nebulizer or the proper form of that antibiotic. What we use is we use the normal nebulizer and the IV form. But practically, it is, patients are responding well. So practically, we use for the ventilator associated and the severe pneumonia. So, but,
Although I came back, I didn't miss any of this one. Yes. Two questions. One is ATT. Treatment itself composed of antibiotics. So for especially surgical patients, we may use antibiotics after decortication. We may add some antibiotics on top of ATT.
Yes.
What are your recommendations on that?
If
we are, because anyway, surgical patients are given, prophylactic antibiotic reduction.
yes.
Those separate, we might add some antibiotic on top of ATT.
If there is a empyema, if there is a growth of another organism, we have to treat.
Specifically.
Yes. Specifically, we have to treat.
Is it specific narrow spectrum for TB only, or is it broad spectrum?
Rifampicin is kind of we are using rifampicin for other treatments as well, but it has a gram-positive cover. Usually what we isolate is mostly gram-negative. So in that case, we have to add another antibiotic. Yes. Usually this, TB, even this Mycobacterium tuberculosis is not, we are not classified from the gram stain because it's not stain, but it's kind of a gram-positive range. So these antibiotics for this TB is mainly for that spectrum, gram-positive spectrum. So in that case, we have to add something. Usually we isolate gram-negatives.
And the other query is, so as surgeons, when we put some implants or meshes on the body, we tend to use this gentamicin vial and break it and instill it. Is it just because anyway patients are given prophylactic antibiotics to start. So are we to stop that, or is there any evidence to that?
It's like these implants, these prosthesis and all, there are these antibiotic beads and all. That is like worldwide they are using that. But just to put this vial is not recommended. There are these antibiotic, there are implants with embedded antibiotics, especially used for these hip replacements, knee replacements, especially with the, infected hip or these implants. There are things, but not for the other things.
When we talk about this which you have already introduced it.
Yeah, we are using. Actually, I have planned another lecture, and I asked the planning MO to distribute. Not none of the doctors came, so I just introduced to the nurses.
Just how you how you been having this allergies working on that no?
Yes.
The just to caution the staff. There are people who come for admissions while on treatment, just take a leave and go off and come back. If it's a BHT and just you are strictly crafting and get on with the management the next day, day after
Yes.
they come. Then you tend to forget the initial part of allergy.
Allergies.
And that may not just be, they may be overlooked. Something happened in my watch some years ago because patient went on a couple of
Yes.
days. He came back. His garment slab allergy was not documented because somebody else will all the same come to the same lead. You know the patient for many
Yes.
many weeks.
Yes.
And then we already tried this.
Yes.
So whatever the admissions they have to go through.
Yeah, if
That-
we introduce this form and if the doctors are filling it, that would be noted. I mean, they have to ask that part and fill it.
And also, once you finish, once you finish it, why don't we go for a pilot thing on an audit, how we are doing it and how we're reducing, how we are.
Initial audit we have done, antibiotic audit in this hospital we have done. Dr. Darshan has done that. And thereafter only we have introduced this, but it was not properly implemented. So I can't do a post-implementation audit yet, sir, because
For this also, you
Yeah.
do another audit and
Yes.
these trainees can start doing an audit because we have DTC trainees who are coming in.
Yes, but
Months time.
by introducing this form, we are expecting to reduce the use of antimicrobials. But I mean, it's like sometimes these patients are started on antibiotic and these antibiotics are going on. Sometimes I find that some patients are on 30 days of antibiotics. So, I mean, this thing, if we use this properly, we can recognize those things.
And we note when we were in training in UK and the clinical pharmacologist used to visit the
Yes.
waters with a green pen, they mark, do you need it?
Yes. Yes, that's the thing. That part lacks here. And the other thing is we use, I mean, what I recognize there in UK was like my center, they have the past antibiograms. Back in 1970s, they had the same resistance like us because they use antibiotics a lot. Then they have controlled it. They have controlled it superbly, and now they don't. I mean, we have just released 4 antibiotics for blood cultures, gram-negative blood cultures. We released just 4 antibiotics. Just the ampicillin, amoxiclav, ciprofloxacin, and gentamicin. Almost always, all those 4 are sensitive. So even I have seen only 2 MRSAs there. All are methicillin sensitive. But here I can't, I mean, we rarely see MSSA. I mean, almost always it's MRSA. So, I mean, we have to reduce the use. I mean, we have to control it, not the reduce, just control it.
It is forming our DHA now. Oh,
Nowadays, it's not there. I mean, I have introduced it back in October, initial week of October. So they, all the world wards, they have this. They had it and they used it, but doctors are not filling, nurses are filling. So that was the problem I had. When I introduced, I initially, asked for the doctors to come. Doctors never came. None of the doctors come, but the nurses came. So with that, because ministry is right pressurizing, because of that I have to introduce it. So I just distribute the charts. Now the charts are not there. So they have to ask for the charts. They haven't printed yet. So we don't have charts now.
no. That's we were released a program of antibiotic management with the college or ministry. What steps can we take to control the misuse in the private sector? Day-to-day practice in the private sector. In the hospital setup, anyway, there's
Yes.
self-control, availability of
Yeah.
that kind of antibiotics. But when you talk about
Yes.
the private sector,
sector.
the misuse of loans and all those things are
Yes.
very rampant.
Yes.
And they come and even the red line antibiotic they promote. Sometimes
Yes.
they come and promote this is And sometimes you are doing a illegal thing against the ministry policy and all this, right? And don't
Yes.
promote this to the ascend the GPs and all these people.
Yes.
You go and talk to the consultant in the hospital, not to these OPD guys here.
Yeah.
If you
It's
can-
very difficult in our country. Actually, we are trying, but it's not ministry, it's not supporting. It's
And I
very
remember
difficult.
2006, I was one of the association consultants. There was one, there was this, from the College of Pulmonary, Professor of Pulmonologist, arranged one pharmaceutical company sponsored evening lecture on antibiotics. And there was this microbiologist made from South Africa, white man, coming and talking about, he has done some research on Southeast Asia's antibiotic resistant pathogen. He was saying, I have studied this, Southeast Asia. I have studied in Bangladesh, I have studied in the patterns in Pakistan, India, but Sri Lanka for some strange reasons. Quinolone resistance is so much in this country. I cannot understand the reason. We all knew the reason, but we could not know literal. So it was choice of antibiotic for those days. They broke, then they came into the
Ciprofloxacin actually, it's a bit of a tricky antibiotic because if you give 1 or 2 doses, it becomes resistant. There's no point in giving ciprofloxacin much. It acts on Pseudomonas, but thing is, develop resistance quickly. I mean, if you can see that most of these patients, COPD patients, initially they have this Pseudomonas sensitive to Pseudomonas, sensitive to Cipro, and later on the next, it becomes resistant. Once we give the antibiotic, it will develop resistance.
The practice of providing a prescription for 3 days of antibiotics from OPDs. How are you going to tackle that? That's very common. 3 days antibiotics in a day. If it is antibiotic, that's okay. But this amoxicillin for
Yes.
oxygen for 3 days,
Yeah.
even for the GP, but not in hospitals, OPDs,
Yes.
it's very common.
Actually, sir, we are in the community setting also, we are doing these antibiotic programs to the community MOHs and all. I don't know how effective those, because however much we tell, people are like, I mean, they do their practice. But, I mean, what they want is to...
Kalani, in the need, what they say, we are practicing the Western medicine, but we are not in the Western system.
Yeah.
So after 4, we are selling antibiotics, right? So if you don't have the Western system, with registration,
Registration,
system,
yes.
or somewhere registered or registration, you can't do.
Yeah, even in
Also-
GPs in UK, they only prescribe amoxicillin. Other than even just call amoxicillin, they call us.
Is to get an appointment for the GP takes about 2 weeks by that time.
But it is resolved anyway.
Primary care setup they're going to start. So it's good because I think 3-4 years ago we had this big meeting for this primary care setup. I think myself, Welisara and Diyalagoda, President of College, there is long, it'll be really meeting then the government's change, and I think it's 2018. Here is a big thing. So that is a very good thing out of it.
And over the counter, you can
Yes,
get the antibiotics. That's the
yes.
biggest problem.
that is another problem, biggest problem.
Prescription of antibiotics.
Now it's very difficult to.
But I saw recently a paper and but more is somebody has given some antibiotics over the counter without a prescription. All these people have been fined by the judge, each by all the employees, 200,000, 300,000. Each have been fined by them, they have been asked to put a notice on the paper.
I mean, by law they can't give, but it is happening in our country. I mean, our country we don't have a law.
The generation was for an IV. You want to discharge the patient with oral, but it's
Third generation is cefixime, but please don't use it much. Cefixime is a third generation cephalosporin oral, but I mean, it's a risky drug. Because I mean, this cephalosporin, in our country we don't see much, but in UK, I mean, if we give this cephalosporin, they will end up with C. diff diarrhea. But our setting with our gut and all our foods and all, we don't have it, we don't see it much. But there is high chance of resistance, and this third generation cephalosporin also, this ESBLs usually, some of these gram negatives, they have this, it is called AMC group of beta lactamases, though they are not, once we give only, they will produce these enzymes and start to act. So, if we are giving third generation cephalosporins more and more, especially in the outpatient setting, so these AMCs will be produced, and then once it is produced, it will transmit to other patients. So that this producing thing. So, in the GP setting, this levofloxacin, cefixime, and linezolid should not be used. It's really risky to use these three.
Doxycycline one.
Yeah. Doxycycline, it has an anti-inflammatory effect as well. So most of the infections
You go to pharmacy in a supermarket. One day I did as a test, like I went to the supermarket and asked for a levo. They have given it to me. I called the manager and blamed, but it's very difficult to control. This kind of
The control is much better for tramadol than Borex. Just because of the drug that it's very strict on tramadol. You can they can't take a tramadol tablet from a farm. Not even for antibiotic, antibiotics. And earlier one in one of these forums, couple of years ago, I raised this point. I came to know that hospital. There was no surgeon at that time for 4 years ago. The only surgeon was appointed. They have been using linezolid on. There was this bone care specialist, We've been using linezolid on bones, the diabetic bones, and then that was there and it was great. So this person is my batchmate also, and my contact with the company and said he is the biggest user of linezolid in our country. Means that they are diabetic bone specialists. Until they are locally
Okay. No point in treating diabetic foot wounds with antibiotic because those will be colonized always. No point in treating. Regarding ceftriaxone, usual dose, it's a once daily dose. No need of giving BD dose of ceftriaxone. You can either use, for a simple infection, even 1 gram daily would be enough. But 2 grams daily, in our setting, 2 grams daily would be enough. I have seen.
I asked that problem. And they said for 2 grams, they need a 20 cc syringe to dilute. And the 20 cc syringe is not there. So they have to use 2 10 cc syringes to give 2 grams at once. And the patient might also complain like a lot of drugs are going on. It's not given as an infusion, so it's given as an injection. So that's their concern.
But these reactions and these adverse effects are more. We don't have to give it as BD dose because it's with the pharmacokinetic, it is a long-acting drug. So once daily dose is enough and more renal friendly.
Actually, after once madam showed down, I wrote it like that and they came for it.
For the COPD, usually what we isolate is pseudomonas. In that case, even COPD exacerbations in other countries, they start with coamoxiclav. If it is not responding only, they can go for other, ceftazidime or even ticagrelor. All pseudomonas are resistant to coamoxiclav, but the other organisms are there. Initially, some of these, if you can see, some patients, even though we isolate pseudomonas, they responded to ceftriaxone. Usually, pseudomonas is not sensitive to ceftriaxone. Gentamicin, I think we have, but IV gentamicin is not, for this lung infections, it is not good enough. This usually gentamicin it's a better drug for a UTI and the bloodstream. Netilmicin is not there. Even amikacin is not there nowadays. So gentamicin, that's why I use nebulization. So we just send it to the place. It's more of the practice and all.
For this leptospirosis, prophylaxis with doxycycline is still practiced or still recommended?
It is recommended in this, I mean, there is this post I have seen.
Once weekly dose.
Weekly
Once
dose.
weekly.
Basics.
100 months before starting the pandemic work, 100 monthly till they finish.
About 2 months ago, now they don't have to pick up. Somehow be like that. Yes.
In the absence of any other questions, like, I would like to thank Dr. Kalani Diyalagoda for that excellent presentation. Thank you so much. I would like to thank our sponsors also, Get Farm